Good morning, everyone. Good afternoon, good evening, depending on your time zone. My name is Ohemu Godwin Pius, and it is indeed a great honor and privilege to have every one of you join us today for the World Antimicrobial Awareness Week webinar put together by the Global Health Network, particularly the AMR Knowledge Hub, to increase awareness about AMR and also to translate knowledge to action. So today we are gathered to look at the theme on the screen, from knowledge to action, mobilizing awareness for a resilient future against antimicrobial resistance. So we just give a couple of seconds to our colleagues who are in the waiting room to join, then we will make a start. All right, ladies and gentlemen, once again, you are welcome to the Antimicrobial Resistance Awareness Week put together by the AMR Knowledge Hub of the Global Health Network. Today, we'll be looking at the theme on the screen, from knowledge to action, mobilizing awareness for a resilient future against antimicrobial resistance. My name, once again, is Ohemu Godwin Pius, and I work as graduate assistant at the Antimicrobial Resistance Knowledge Hub of the Global Health Network. As a quick run-through of housekeeping, this webinar is being recorded and it will be shared on the Global Health Network platform. To automatically translate the speech to subtitles in your own choosing language, we request that you navigate to the closed caption function and select your language of choice. Due to the number of participants, your video and microphones have been disabled. We request that you use the chat function to introduce yourself to us. We'd like to know who you are and where you are joining us from. And in case you have any technical issue, you can also communicate with the support team from the chat function. And also, we request that you use the Q&A function to post your questions and comment. You may do so anonymously. Just a quick run through of the agenda or the list of panelists for today's webinar. I am Ohemu Godwin Pius, and I am going to serve as the chair of today's meeting. As soon as we get started, my colleague, the Knowledge Exchange Coordinator of the Global Health Network, Adam Dale, will jump in quickly to give a brief overview of the Antimicrobial Resistance Knowledge Hub of the Global Health Network. Then we'll take our first presentation from Dr. Alun Davies. Then Dr. Kome Otokunefor will also give a presentation. Then finally, we'll take the presentation on data-driven antibiotic stewardship from Professor Esmita Charani. Then we'll have a closing remark. So this will serve as a guide for today's webinar. As I said, please use your chat function to introduce yourself to us.
We just have some connection issues there, Ohemu. Louis, I wonder if we could move on to the next the map slide. Just well, see if we can reconnect to Ohemu, and if not, I'll do a brief introduction around the hub. So this is just to show in terms of registrations where people have come from. I think it's always great to see this, that we've got a very global reach for all of our webinars, and I'll point out a little bit in the AMR hub where some of our members come from as well. But shall I get cracking? If I share my screen, just to introduce myself, I'm Adam Dale. I'm the Knowledge Exchange lead at the Global Health Network. And thanks to Henry for the introduction. And as I said, I'll do a brief outline of the hub itself. But first of all, to perhaps give a bit of background and context in terms of what the Global Health Network is. I mean, you'll hear your members, but just to give a bit of background history, the Global Health Network is around about 12 years old, and it started off really as an initiative with a single hub, a single website, the Global Health Trials, which was really there to accelerate skills for people conducting research and also conducting trials. As the years progressed and as it expanded, several other knowledge hubs came along, and we call them knowledge hubs. They're basically separate websites, but all interconnected within the Global Health Network because there's so much overlap between these areas. And what we have now is a network of around 66 knowledge hubs, training and resources. We are just on the cusp of getting our 1 millionth member, which will be happening very, very shortly, which is it's exceptional if we think of where we started off so many years ago. And we also, in terms of training, have over 4 million training modules have been taken by our members. Just to show you what the Global Health Network is, it's a connection of interrelated training resources, hubs where people can share dissemination of research, but also particularly share resources and then help people develop skills in particular areas. And I think it's worth looking at the different knowledge hubs that we have, not in any great detail, but just to show you what we have across the platform, and particularly for AMR to think about where we can really see the value of improving research skills and understanding of AMR in connection to some of these other hubs. So for instance, we have ones on wastewater surveillance. We have organizations like CEPI have a platforms with us as well. The global malaria research, which I'll mention again in a few minutes, there's some great overlap there with some of the resources which we've got access to across the AMR hub. Each of these is like their own separate area, but they're all connected to others based on the thematic areas. So Al will speak later on around MESH, which is community engagement. But we also have particular spaces as the years progressed, due to emerging threats such as Zika, Ebola, COVID-19. We have particular platforms for those. And we also have our outbreaks hub, which we brought out recently, but also particular organizations like Africa CDC or Fiocruz who wanted their own specific space on the Global Health Network in order to get the right kind of information out to the right people and also get the right kind of feedback from the right people, so that they could really gain an understanding of how they could improve what they do for researchers. So if you haven't had a look for a little while, please do have a look back at the main site that we have. There's also got the various training and resources across the Global Health Network as well. Various e-learning courses. As I said, around 4 million modules have been taken. Of course, that number is increasing as we go. Each of these and all of the information we have across the Global Health Network is open access, it's free at the point of use. And there are various courses in order to help enhance people's research skills. So that's just a little bit of a background to where the positioning of the AMR Hub. The Antimicrobial Resistance Knowledge Hub itself started around 2021 was when it was launched, because of the recognition of the need for a space like this in terms of helping to share resources and training around AMR. It started in 2021. We now have just over 13,000 members who specifically signed up with the interest of looking at the AMR Hub. So it's expanded greatly in the past 3 years. It's one of our most popular hubs, and we can obviously, we're all here today, so we understand why that is. Across the homepage, you have access to resources, access to training. Ohemu does an incredible job at updating with the latest information, and we have access to various webinars, events as well. I'm not going to go through every single page in any great detail, but just to identify some examples. So for instance, we have a page particularly for AWARE, which we work with. As you might know, the Global Health Network is a WHO collaborating centre. So we do have various initiatives with the WHO, and including a specific page for AWARE here. But this is just one of many different areas that we have across the hub on some of the study profiles and some of the partner resources that we have. You can see down here. Another thing I wanted to highlight was some great work that Ohemu's been doing in this connecting and collaborating AMR researchers across the globe. This initiative started, I can't remember exactly when, but a year and a bit ago maybe. And since then we've expanded out to get a huge amount of people who've added themselves to this Connect Collaborate map in order to explain what it is they do and see if they can connect with others on particular areas around AMR, diagnostics, AMS, whatever it might be. As a result of this initiative, we've held several meetings with people across the different regions to try and help connect people up further to enhance work that perhaps people can be doing with each other, and then perhaps share those findings across the platform. In terms of training, I mentioned the training that we have on the Global Health Network as a whole. But there's also a particular training which we can guide you to, which is external to the Global Health Network, which we've added on here, specifically on training on kind of the broader ideas around AMR, on antimicrobial stewardship, One Health, where there's obviously a clear overlap there in terms of the work, the One Health approach to health, diagnostic surveillance sequencing. I'll talk a little around social sciences and vaccines there as well. All of these training courses are accessible, and again, something that we'll update regularly to make sure that we've got the right training to the right people. Some particular pages we thought would be quite interesting, so which have been relatively recently added. On our resources section, we have pages on particular thematic areas relating to AMR. One of these is AMR and conflict. There's a page we put together recently, and again, it's something we're looking at and updating as we go regularly. Please do take a look at that. I've got a couple of links to these pages, which we'll share in the chat afterwards. I can't see if they're being shared at the moment, but if not, I'll do that afterwards. Drug-resistant tuberculosis was another one that we've recently compiled and put together and added to. And there's some great reports on there, some great information, which again, there's some brilliant work from Ohemu on that. And then just the last one I wanted to mention was the malaria drug resistance page, which has a huge body of information around that area. And also it helps, it links up with our malaria research hub that we have as well, where obviously, of course, there's great overlap there. And there's a particular page I wanted to share the link with, which is we've just put together some discussion topics around antimalarial drug resistance, which would be great if any of you could after this webinar, go to and perhaps make some comments on. We'd like to get, so we've phrased a couple of questions specifically for antimalarial drug resistance, and there are some other questions around pregnancy and malaria as well, but for you to have a look at and maybe comment on. It helps guide us in terms of our priorities of what perhaps you might like to see on the AMR Hub and the Malaria Hub as well. It gives us a good idea of where to sort of put our energies in terms of gathering resources for you. So I'm sure some of you have a look at the AMR Hub, and I'm sure you've had a look at the Global Health Network, but if you haven't for a while, please do. And like I said, it's a very brief overview. I will turn now and hand over. Hemi, shall I hand over to you to introduce Elle?
Yeah, I will. Thank you, Adam. Thank you so very much for that brief overview on the AMR Knowledge Hub. Participants, we have shared the links to the various hubs that Adam mentioned. If you want to have a look, that will be fine. And if you have any question that you would like to ask, please do feel free to reach out to us, or feel free to drop it in the chats in the Q&A box, and we'll do our best to serve those questions to Adam if you have any. Ladies and gentlemen, if you are just joining us, this is the World Antimicrobial Awareness Week webinar put together by the AMR Knowledge Hub of the Global Health Network. And today we are gathered to learn how we can translate knowledge to action. And it is an honor for me to introduce our first speaker for today to us before he takes the stage. Our first speaker for today leads METCH, the Global Health Network's platform dedicated to advancing community engagement in health research. With a network of coordinators across Africa, Asia, and Latin America and the Caribbean, he supports skill, knowledge, and resource sharing among engagement practitioners and researchers. Among his achievements, our first speaker for today established a prominent school engagement program in Kenya under the Kome Welcome Research Program, initiated in 2009, and now a celebrated part of the program's public engagement strategy. Additionally, our first speaker for today has guided engagement for various multi-country projects in Sub-Saharan Africa, Southeast Asia, and South America, including leading a WHO technical working group on good participatory practice for a COVID-19 vaccine trial. His PhD research in public engagement evaluation utilized mixed methods and participatory approaches, including participatory video to assess engagement impact and outcome. Without further ado, ladies and gentlemen, please join me in welcoming Dr. Alun Davies as he makes his presentation. Dr. Alun, if you are ready, we are ready. Over to you. Thank you.
Yeah, thanks, Ohemu. Thanks for that introduction. So I'm going to be talking about engaging communities to tackle AMR. So I lead, as Ohemu said, I lead the MESH, which is the Global Health Network, the Global Health Network's hub and knowledge community for community engagement. It has a community of about 5,000, just over 5,000 practitioners. It's a repository of resources. For example, our training on community engagement and involvement with health research, which was co-funded by NIHR, is very popular at the moment. We have regional coordinators, as Ohemu mentioned, and their work involves building the network in the regions, strengthening capacity for community engagement, and also highlighting excellent engagement practice within the regions. So what I'm going to do in this talk this morning is to highlight some community engagement initiatives that have been done around the world and which are highlighted on MESH. There are, however, these are not the only community and public engagement initiatives that have been published. There's a growing literature in this area. According to that literature, some of the goals for community and public engagement with AMR is to raise public awareness and address misconceptions. For example, the misconception that antibiotics are cure-all and they can be taken to treat viruses. To empower individuals to make informed decisions and adopt practices that reduce the spread of resistance. That includes responsible antibiotic use, good hygiene, and uptake of vaccination. Then there's to encourage community-driven behavior change and to draw from community insights to inform both engagement and research initiatives, and to foster grassroots support for AMR policy change, and to foster collaborative action among stakeholders from government, healthcare providers, veterinarians, farmers, and communities. So I'll show some projects which have aimed to address all these goals now, and they're highlighted on MESH. So the first one is a framework called Responsive Dialogues, and this is a framework for public and stakeholder engagement developed by Wellcome. It involves deliberative discussions about AMR between members of the public, health, and other stakeholders and scientists. It's broadly aimed at developing solutions to tackle AMR, for example, to improve understanding, attitudes, and behaviors towards AMR, to empower the public to develop community-driven solutions, and also to contribute to policy making. On MESH, we highlight two projects which have used this approach. In Thailand, the Mahidol Oxford Research Unit held regional and national conversations with 248 participants, and that led to improved understanding and attitudes towards AMR. It led to the development of community-driven communication strategies and local action plans, and also education materials. So in terms of impact on policy, the project managed to incorporate community voices into actionable plans, which aligned with Thailand's national strategic plan on AMR. Malawi, the Malawi-Liverpool Wellcome group worked with women's groups, and their conversations, their dialogues led to increased communication on daily hygiene, the installation of low-tech hygiene facilities in schools, wash equipment, and refuse collection materials. And in terms of policy, it led to the Ministry of Health committing to scaling up some of these locally developed interventions. So another approach, again by the Mahidol Oxford Research Group, is a drama, the community theatre called Fishy Clouds. So, and this community theatre drama was developed drawing inputs from scientists, from farmers, and from a theatre group. And the script and the play itself was developed in collaboration with these groups. They held 12 community shows to an audience of an estimated 1,500, and the impact was evaluated through surveys, interviews, and focus group discussions with audience members. They found that there was an increased interest in public health and science, and a modest gains in terms of AMR specific goals. But importantly, it kind of highlighted an appropriate, enjoyable, and engaging means of reaching out to quite large audiences. So moving to India, this project from the India Alliance is highlighted and is described in MESH. And this is called Superheroes Against Superbugs. The project engaged school children through fun, hands-on learning activities and interactions with scientists based on the educational approach called Child to Child. In this initiative, children were encouraged to develop plays, posters, and comics to engage their peers. They evaluated through pre and post surveys and focus group discussions, and their impact included improved AMR understanding for participants, the installation of hygiene equipment with instructions in schools, the inclusion of AMR content in school programs, and lastly, increased number of researchers taking part in community awareness workshops. So just pointing to a very useful resource that's also, which can be found on MESH. This is called the CE for AMR Handbook of Community Engagement for Antimicrobial Resistance. It's a resource for researchers, healthcare workers, and others interested in using community engagement to address antimicrobial resistance. It describes community-centered approaches, and it provides a step-by-step strategy to planning engagement processes. What's really interesting about this is that it really presents real-world cases of engagement projects. For example, there's a multi-pronged approach in Tanzania which incorporates community AMR ambassadors, where community leaders or trusted kind of knowledge keepers within the community are working with those community leaders to give messages about AMR. And this project in Tanzania led to improved awareness and behavior change related to AMR. So there's some of the examples of community initiatives which are highlighted on MESH. I'll now talk about an initiative that I was involved with called the Youth Against Antimicrobial Resistance, or YAR. And this was a 4-country project in Kenya, Nepal, Vietnam, and Thailand. So the project objectives were to understand AMR awareness among children and young people in the 4 countries. Secondly, to develop a learning framework which could be used in learning activities both inside and outside schools and educational establishments. To create engagement platforms for children and youth involvement in AMR. And lastly, to co-create AMR messages and engagement activities for youth and children. So to lead the project, we had several youth working groups. We had a youth advisory boards, which comprised of young people representing the 4 countries. Locally, in the 4 countries, we had youth working groups, and they were groups of between 10 and 12 young people who met regularly. And then we had a wider group of young people who took part in data collection and were involved in the engagement activities. So young people were involved in the survey development, the implementation and analysis of that survey. They were involved in the co-design of engagement activities, which involved a range of poems, skits, stuff on social media, and on the website, and learning materials, interactive activities with scientists. They also took part in evaluation and in the co-design of messages for social media. And we counted that through social media messaging, we reached over 500,000 people in Asia and Africa. So the components of the project that I was most involved with, I mean, drawing, I guess, from, I've got a background in science education, was to the collaborative development of an AMR learning framework. So we work collaboratively with science teachers, scientists, and curriculum developers from the 4 countries. And we started through reviewing science and health education curricula for any content within the curricula related to AMR, and the teachers took part in this activity of combing through the curricula. Excuse me. Then we prioritized content, AMR content for the learning framework based on the survey, based on workshops with experts, and also based on a literature review that we developed. So drawing from the curricula, we developed age-appropriate AMR learning outcomes based on the curriculum review. So this framework was then posted up on Zenodo, and has been downloaded several times, several thousand times. And you can get this learning framework from Mesh, as well as all the materials that I've and the examples that I've talked about during this talk. Just lastly, just going to take some time to flag up the training that we have that I mentioned right at the beginning. If anybody's interested in learning new skills and learning how to think about community engagement across any aspect of global health research, this course is freely available on Mesh. If you look at that QR code, if you scan that, then you get straight to the course. And there are modules on introduction, principles, evaluation. Yeah, there you go. Thank you very much.
Thank you so very much, Dr. Alun Davies, for that very insightful presentation and analysis on engaging community to tackle antimicrobial resistance. Quite a very enlightening presentation, showing us the works and projects that you have, led in the past, and how impactful most of this project actually has been. Thank you so much. So, participant, if you have any question that you would like to ask Dr. Alun, we request that you drop your question real quick in the Q&A box so that we can feed them straight to Dr. Alun, and he will give his professional advice on that. At the moment, I don't think we have any question yet, Dr. Alun. However, I will request that you hang on a bit, probably as time goes on. Okay, now we have a question. We have a question. Shakira Babri, I'm sorry if I didn't pronounce your name very well. Shakira is asking, is there any project that you have led using mathematical modeling or any form of modeling or machine learning on fighting antimicrobial resistance?
I haven't led any program in this area. I'm afraid. I guess my field is in community engagement and public engagement. Maybe some of the other speakers have had experience in using mathematical modeling.
Okay, that's fine. Thank you. Probably Dr. Kome and Professor Esmita might have similar experience, and they will be able to share their view on this as we proceed in the conversation. Thank you so very much. I think that's all we have as a question. If there are new questions, we sure will let you know as we continue in the course of the presentation. Once again, thank you so very much, Dr. Alun Davies, for that nice presentation. Okay, let's just get ready as we make welcome our next speaker for today. I'm going to quickly introduce her to us. Louis, if you don't mind, we can go to the second slide or the next slide. Yeah. All right, ladies and gentlemen, our second speaker for today is an associate professor of molecular and medical microbiology in the Department of Microbiology at the University of Port Harcourt. She earned her PhD in molecular microbiology from the University of Nottingham, an MSc in medical and molecular microbiology distinction from the University of Manchester, and a BSc in microbiology first class honors from the University of Port Harcourt. With nearly 20 years of academic experience, our second speaker for today is deeply committed to combating antimicrobial resistance through collaborative research. Her work extends to exploring bacterial virulence, identifying alternatives to current antimicrobial therapies, and typing bacterial isolate to trace routes of spread. She has made significant contribution to curriculum development for graduate programs in pathogenic microbiology and has supervised over 100 undergraduate and 15 masters, 100 undergraduate, 15 masters, and 15 PhD students. Our second speaker for today is passionate about mentoring the next generation of scientists and demystifying molecular techniques for practical research. She has presented her findings at prominent microbiological conferences, including those organized by the American Society for Microbiology and the Federation of European Microbiological Societies. Additionally, she has participated in advanced training courses such as the Wellcome Trust Molecular Approaches to Clinical Diagnosis in Africa. Ladies and gentlemen, without further ado, join me in welcoming Dr. Kome Otokunefor as she makes her presentation. Dr. Kome, if you are ready, we are ready. Over to you now. Thank you.
Hello, everybody, once again. It's always a privilege. I'm always glad to give a talk on antimicrobial resistance. Today, I'm going to be talking on the role of political leadership in strengthening antimicrobial resistance resilience. And this is the outline of how my talk is going to go. When we think about antimicrobial agents, quite a number of us will be aware that we refer to chemical substances which may be synthetic or natural. Basically, they act against organisms, they kill or stop their growth, and they can be used in several ways: prophylaxis, therapy, and as growth promoters. Antimicrobial agents play a role not just in human health, but also in animal, and they serve one of several roles. However, we have the issue of antimicrobial resistance. Thinking about antimicrobial resistance, you're thinking about the ability of these organisms to withstand the action of the antimicrobial agent. Essentially, these antibiotics have been rendered ineffective against the organism. And quite often, this resistance develops rapidly after the introduction of the drug. If we look at the picture on the right, there are two different organisms on plate. We have an organism that is resistant and an organism that is sensitive. For the organism that is sensitive, this is indicated by the areas of clearance around the different antimicrobial discs. But this picture on the right tells a different story. In that picture, we can see that the organisms are growing right up to the antibiotic list. And most often, in most cases, this indicates that these organisms are resistant. Antimicrobial resistance is a problem. Over the years, antimicrobial resistance has developed rapidly as organisms, as drugs were introduced into clinical practice. I think one of the most interesting cases was the case of methicillin, which was introduced in 1960. From our chart, we can see that methicillin resistance developed in that same year. Actually, literature said that methicillin resistance developed like 3 months. Some studies say it was detected even before methicillin was introduced into clinical practice. And what this tells us is that there is a problem, and this problem has to be solved. There are several consequences of antibiotic resistance as of today. If we look at the data as captured in this chart, we're seeing that antimicrobial resistance is a top global problem. We're looking at estimated deaths of 700,000 deaths a year. Some studies have said estimations by 2019 were up to 1.27 million per year. And antimicrobial resistance, this was direct deaths. But antimicrobial resistance contributed to 4.95 million deaths globally in 2019. That is a staggering amount of deaths. And then we look at, this is for today, but in the future, what are we looking at? We're looking at an estimate of 10 million deaths per year by 2015. Some people have said this has even risen, the numbers that are estimated. Not just the death. Antimicrobial resistance is not just a problem with relation to death and disability. We're looking at its effect on economic cost. There's money that is going to be lost in economic cost. Global production, people are sick, they cannot work, money is not made as it should be. So we have antimicrobial resistance affecting all aspects of life, essentially. This effect is not the same globally. The burden of antimicrobial resistance differs, and the higher burden are found in lower middle income countries. Looking at this chart, we can see that an estimate is made of 4.15 million deaths in Africa, which is a lot compared to the estimate seen in other places. So what can we do? For humans to fight against antimicrobial resistance, the concept of resilience has to come in. When we think about resilience, we're talking of the capacity of a system to respond to disturbances, to manage surprises, and to maintain vital functions. These responses could be a number of things. The system could cope, adapt, or transform. Those are one of the different things the system could do. That's a resilient system. For antimicrobial resistance, what this means is the system is able to continue to ensure effective therapy, maintain or improve economic, social, and environmental health and well-being. There are different types of resilience that we could come across. We have driver resilience, pressure, state, and impact resilience. When you think about driver resilience, you're talking about the capacity of the system to prevent or control factors that increase the need for antimicrobials. This is key because sometimes we think about antimicrobial resistance as something after the fact. Like there's an illness, we're giving a drug and the drug is not working. But the question is, why don't we first prevent the illness? If there is no illness, if there is no sickness, then we do not have a need for antimicrobials. Then we're not thinking about the concept or the problem of antimicrobial resistance. And that's where the concept of vaccination comes in, prevention comes in, and all of that. And then when we think about pressure resilience, we're thinking about the capacity of the system to maintain antimicrobial use when a driver increases. This sometimes might not be so easy to handle because if we have an outbreak, how are we supposed to maintain antimicrobial use? We're probably going to give more antibiotics to affect, to influence, to stop the disease outbreak. So those are the two things that we could focus on. Resilience, on the other hand, could also talk about the capacity. What is the capacity of the system So we think about absorptive capacity, adaptive capacity, and transformability. When we think about absorptive capacity, we're thinking about the ability of the system to absorb disruptions. How does it still continue? And then adaptive, how does it change? This change can be proactive or reactive. Like I said, we could prevent the illness before the fact, or we could think of the antimicrobial resistance is in play, what do we do? And then transformability, the ability to create a new system. An example of an absorptive capacity can be seen with the Netherlands story. Remember, absorptive is the ability to absorb disruptions. So Netherlands, as far back as the late 1980s, initiated a search and destroy policy. It was targeted against specifically methicillin-resistant Staphylococcus aureus. This began in the 1980s, and it was basically aimed at screening, active screening, isolation, and decolonization. And it has been so successful that currently Netherlands has one of the lower rates of antimicrobial resistance for methicillin resistance compared to other countries. When we look at this chart, it represents an example of what we're talking about, the absorptive capacity. We look at the figure right down at the bottom. We see the data for Netherlands. It's consistent, it's constant, it's really low. And then we look at the data for other countries, other European countries, 7 European countries specifically. What I want us to focus on is the data for the United Kingdom. If we look at this, is for methicillin resistance. United Kingdom initiated in 2004 a targeted search and destroy for methicillin resistance, targeting people that were at higher risk. And this had, what it did is there was no increase in the number of methicillin resistance, and there was actually a reduction over time. By 2010, the scenario changed. If you can see the data between 2010 and 2011, there's a continuous drop. There was a steep decline. By 2010, the United Kingdom was the first and only country to introduce a universal screening policy. In that case, all patients in all healthcare facilities were asked to be screened for methicillin resistance when first admitted. And we see the effect it had on the rates of methicillin resistance. I've given you scenarios looking specifically at humans, but the antimicrobial resistance story, the fight against antimicrobial resistance cannot be carried out on only one front. There is a need for a One Health approach, simply because antimicrobial resistance is taking place at different fronts at the same time. While looking at human beings, there's antibacterial use in humans, and then this is creating antimicrobial resistance. The same thing is happening in animals, and there's an interconnection between the humans and the animals. There's a move between the two systems. And then we have the environment that is at the receiving end of it all. We have manure being fed to the environment that sometimes has antimicrobial resistant organisms or antimicrobial resistant genes. We have runoffs, we have wastewater treatment. And so the One Health approach is essential for tackling antimicrobial resistance. To highlight this, there was a study, a 2014 study. This study began with the Netherlands was trying to evaluate the program, the search and destroy program. And as we can see from this graph, the white bars show what is known source of methicillin resistance, not animal related, and the numbers are not increasing so much. But then we can look at the gray bars, we can see there's an increase in animal related methicillin resistance. What this means is if the only focus is on antimicrobial resistance in humans, we're still going to be having a feed from other sources, and then the fight against antimicrobial resistance will not be won. A resilient system would have different abilities. We could look at all of these are factors that can speak of a resilient system. And we're looking at both technological transfer, disease prevention, access to clean water, zero hunger. Because if we're talking about reduction in infection, A society that is riddled by poverty, has hunger, doesn't have clean water, it will be difficult to talk about disease prevention because we're going to expect that there's higher levels of disease in those systems. All of this involves the deployment and implementation of policies. And that brings us to the question of why political leadership. Basically, all of these characteristics we see of a resilient system with respect to antimicrobial resistance cannot be done in silos. The response must be system-wide. It has to be globally coordinated. Think about a country has reduced the levels of antimicrobial resistance, but currently the world is a global village. You can have importation of antimicrobial resistance from one country to another, especially when you think about the concept of medical tourism. It's possible. And then monitoring is crucial. How are we going to know what the situation is if there's no monitoring carried out? Funding underlies all of this. It will be very impossible to carry this out without funding. International collaborations then have to come into play, especially when you think about the concept of lower middle income countries that have a higher burden, probably having less funds available to fight antimicrobial resistance. When we think about political leadership, it's not a new concept. Political leadership has worked with respect to antimicrobial resistance. It has worked. Looking at the United Kingdom, this is some facts from the United Kingdom. Currently, the United Kingdom was one of the first countries to establish a national action plan on antimicrobial resistance. This started way backward in 2013 with a strategy put in place. And then by 2019, they delivered on their first national action plan against antimicrobial resistance. Currently, there's a 20-year focus for this. And this focus, it has 4 different themes, and these are aimed at addressing 9 strategic outcomes, as highlighted on the slide. We're thinking about reduction of antimicrobials, of the need, the use, and the exposure, optimizing use, investing in innovation, supply and access, and being a good global partner. This presentation will be available to us. This gives details of what exactly this looks at. And if you look at this, it highlights different things: infection prevention and control, and then you have waste minimization and effective waste management. It's showing how the different One Health themes have been touched in this National Action Plan. And then how has this translated to everyday things? I was looking for examples of how this has translated. And one of the things I saw was by May 17th of this year, 2024, new veterinary medicine regulations were introduced. These are further restricting the use of antibiotics in livestock simply because of the impact they have and highlighting the need for a One Health approach. And then we can see at the bottom left corner, a continuous monitoring of this is what is happening. We have a problem. Thank you for doing your bit. We have an World Antimicrobial Awareness Week coming up. These are actions that can be carried out to reduce this. In 2016, there was the Davies Declaration. This was formed by over 100 biotech diagnostic, generic, and research-based pharmaceutical companies. Basically, it's an industry alliance, antimicrobial resistance and industry alliance. And they had a shared goal at the bottom, curb antimicrobial resistance globally, as highlighted here. Then we have a global picture of all of this political leadership, political will that is being harnessed. A recent study, a 2023 study by Patel and colleagues, set out to condense all this information. They studied different countries to see what has been done, what can we improve. If you look at this, there's a color grade. Teal is the highest, and while orange is the lowest. And we can see how this is carried out, how this is being done globally. I must highlight that the gray areas, what the gray areas show is countries that they don't have data for. Africa, you can see there's a lot of gray areas. So nothing, information is not coming out on what has been done. But looking at the overall antimicrobial resistant governance scores, we can see countries that have the highest scores. And this oftentimes correlates to the developmental level of the scores of the countries, with lower middle income countries having lower scores. And this differs. Policy design, we can see, looking at my country, Nigeria, the top right-hand picture. For policy design, we have a higher score compared to overall antimicrobial resistance. Implementation, by the time of implementation, the scores start to drop. And then when we're talking about specifically monitoring and evaluation, that's where most countries are having a problem. Without proper monitoring and evaluation, it will not be possible to say how is the political will translating to commitments to ensuring sustained action and investment in antimicrobial prevention. We can say one of the wins for antimicrobial resistance was this year at the 78th United Nations General Assembly meeting. There was a high-level meeting on antimicrobial resistance, and these are the details. They highlighted why. I think this was like one of the highest levels of advocacy that have been done so far. They highlighted why antimicrobial resistance has to be dealt with. Previously, we were talking about a tripartite organization, but at this point now, we have 4 different organizations working together to handle antimicrobial resistance and a political declaration coming out of that. There are several key points that were highlighted of what can be done. Reduce estimated antimicrobial death by 10% by 2030, set up sustainable national financing, the global multisectorial need, and a call for 95% of countries to annually report on implementation. This will improve that data we saw. All of this, the successes we've had up to this point, honestly, they couldn't have been possible in the absence of advocacy. For us, the fight against antimicrobial resistance to have got to the point, people have been speaking up. So the question is, when we think about advocacy, we think about how will people hear? The policymakers, they need to hear. Advocacy comes in place. Who should be informed? Who will do the informing? And how will this information be passed on? For policies to change, people have to be aware of what's going on. Advocacy is key. We think about advocacy, there are several advocacy groups currently. These groups are of different types. Some are patient-based. You have the Task Force of Antimicrobial Resistance Survivors. You have Antimicrobial Patient Alliance, Antimicrobial Narrative. You think about the Global Health Network AMR Hub, Alliance for the Prudent Use of Antibiotics. All of these are advocacy groups. And what they've set out to do over the years is to inform about the problem, to carry the news of antimicrobial resistance far and wide, so everybody is aware and we can have policy changes. This is a collective responsibility. It's not for one set of people. We all have to be involved in combating antimicrobial resistance. When you think about that, sometimes a person can be in the community. This talk just before mine spoke about community awareness. Imagine people in the community telling their neighbor, why are you treating? Have you tested? It's something as simple as that. People being aware of antimicrobial resistance, of how it is spread. And so we have to find ourselves in the story. Every one of us can be an advocate, can be part of the advocacy group for antimicrobial resistance. In a nutshell, the gains in antimicrobial resistant policies, they are not accidental. How far we have come so far reflect years of advocacy, people telling the antimicrobial resistance story. It seems in the past 5 years, there's been a momentum gained in antimicrobial resistance awareness. People coming and chipping together to say, how are we going to handle this? This is small deliberate steps leading to what we have right now. The momentum must be maintained. We cannot relax now and say we have reached a place of success and it's going to be done. No, all hands have to be on deck. And so what I would ask, are you willing to be a part of this story? Are you willing to join hands? Let us together end the scourge of antimicrobial resistance. Thank you.
Wow. Ladies and gentlemen, if I say I am blown away, that is an understatement. This is a stellar presentation. Thank you so very much, Dr. Kome. This is very, very wonderful, very impactful, and in fact, it is information loaded, rich, vital points, experiences, research studies that has been done in different locations concerning antimicrobial resistance and how the government can be fully involved, how we can actually get political leadership to increase awareness about AMR and also to put an end to whatever the situation is in our various settings. Thank you so very much. I listened carefully and I took note of the point that you have raised. So, participants, if you have questions that you would like to ask Dr. Kome, please drop your question in the Q&A box and let's serve them straight up to Dr. Kome. Dr. Kome, I have a question for you here from Nkwam Jacob. He's asking what's the indicators to evaluate. Okay, let me just look at it carefully. Okay, what are the indicators that one can use to evaluate the resilience of a health system, and how resilient a health system is in Africa? It's not as clear, but I believe you get the meat of it. What are the indicators that somebody should look out for when you want to to measure if a health system is resilient? And can you say that the health systems that we have in Africa, are they actually resilient at the moment, or there is room for improvement? That's the first question for you, ma'am.
Okay, thank you for that question. When you think about the resilient system, like I said, you think about a system that is able to absorb the different drivers of resilience. You think about a system that has the capacity to prevent or control factors that increase the need for antimicrobials. If you're thinking about this system, what's their infection rate like? If you think about in sub-Saharan Africa, often we are said to have the highest rates of infections. So that shows that resilience in terms of driver resilience is not so high, because you have a system that should prevent or control the factors that increase the need for antimicrobials. One of those factors is infection. If we cannot control our burden for malaria, for HIV, for tuberculosis, for childhood diseases, all of those are ways that you judge the resilience of a system. And then you're thinking about the capacity to maintain antimicrobial use when a driver increases. Does the system have the ability? Can we maintain antimicrobial use? For us here in Nigeria, we're still talking about over-the-counter purchase of antibiotics. That is a very big problem for antimicrobial resistance. Anybody has access to antimicrobial agents, and it doesn't reflect a very resilient system. Do we have the capacity to maintain, stabilize, or reverse resistance? All of those come into play. Our diagnostic system, how far is it? Diagnostic is a key. Diagnostic is a key for determining the organism that is causing the infection and the antibiotic is resistant to, so that proper therapy is initiated. These are the different parameters that can say if a system is resilient. Hope I answered.
All right. Thank you so very much. Thank you, Dr. Kome. So the next question for you is very short and I want to keep it straight. What effort do you recommend to promote IPC and WASH in Africa as a continent, and even in your country, Nigeria? What do you recommend? What effort do you recommend to help promote IPC and WASH on the African continent? That's another question from a participant on the call.
Okay, that's really a good question. I was part of the World talk of yesterday, and I think this was effectively dealt with. I recommend you check up their recordings, right? I recommend you look up the recordings of the webinar we had yesterday. Things are happening. We might not be aware. Hospitals are being more aware. We had the clinical microbiology consultants saying of how in their hospitals they are setting up IPC and WASH protocols. So they are designing things, putting things in place to prevent this. And I think this is just a story we've heard from two people. I believe this is cutting across. So different countries are plugging in. They are seeing what can be done, and they are setting up to prevent, for infection prevention and for what.
So sorry, so sorry, so sorry, Kome. I think I lost network. We are in Nigeria together, and you know how difficult it is of recent to get network connection. Sincere apologies for that. Okay, so the last question that you were trying to answer was on what you recommend as per effort that can be implemented to tackle WASH and IPC issues in Africa. As you rightly said, yesterday conversation centered a whole lot about, bringing on board some clinicians to share their experiences as per how how they've been able to curb the rise and the spread of AMR in their various settings, and they mentioned very very keenly the issue of WASH and IPC. The recording for that webinar will be made available on the Antimicrobial Resistance Knowledge Hub of the Global Health Network in the next couple of days. So please, participants, we advise that you check on the hub. My colleague Adam will drop the link on the hub. You can check on there, and you get to listen to what Professor Laura Ibinabo Oboro shared, and what Dr. Mary Alex also shared as per IPC and WASH. Dr. Kome, I have a question here for you, and I was wondering what your thought might be. I would like you to shed more light. You talked about the issue of importation of AMR gene from one country to the other, and you made mention of this also could occur from the high rise of medical tourism. This is something that is strange to some of us. We might just be hearing this issue of importation of AMR gene from one country to the other for the first time. And I was wondering if you'd be happy to shed more light by what you mean by importation of AMR gene. Do we import AMR gene as a commodity from one country to another country, as much as we import goods and services from here, to there? So just your thought on that. Thank you.
Okay. We've had scenarios where antimicrobial drug-resistant organisms were imported from one country to another. I think sometimes there are controversies surrounding them, but one that comes to mind is the new Delhi metallophosphate resistant organism. So when this was first detected, I think in Europe or the UK, you can see the name. There's still a campaign to change the name. So doing a contact tracing, it was found that this individual that had this resistant organism that hadn't been seen before, it was quite novel, had gone to another country, and I think had a medical procedure done in that country and come back to a different country. So that's the concept. We have people now moving from one country to another for medical services. So you can move from a country that has a higher resilience to a country with a low resilience. And then when you're coming back, you're not just coming back with your good health, you can also be coming back with organisms that are resistant. You have new resistance. So it's quite an issue.
So in such situation, what do you advise we do? Sometimes you might fall ill and you need to seek medical services in another country. As you rightly said, you might be coming back not just with good health, but you might, unconsciously import some resistance gene, as you are coming into the country. What measures do you recommend should be put in place to guide against such importation of antimicrobial resistance gene from country A to country B, or from country B to country C?
Is there any measure that can be put in place short of decontaminating every individual, which might not be feasible? That's why we have the need for a global concerted effort. A scenario where country B does not have this resistant organism. You have built the system of country B to such a state that country B is not a developer or is not at risk for the development of it, so that it does not import it to country A. It just shows why we cannot do things in silo, why we have to carry out the antimicrobial effort in all countries at the same time. Everybody should be at par in the fight against antimicrobial resistance.
Thank you so much. Then finally, for you, ma'am, is the issue of poverty. You did mention this in the course of your presentation, and I was wondering if you could shed more thought or shed more light on what is the role of poverty in the rise and spread of antimicrobial resistance in low resource settings.
Well, if you think about that, why I was mentioning sickness and illness. When you have people, there's poverty, the immune system is not going to be as resilient to fight organisms coming against it. Poverty, you have probably no good water source that puts the individual at risk to infection. Poverty, you have a higher way of organisms being spread from one person to another. So the risks are enormous, really. And once you have a scenario where people are going to be sick, then you're basically going to select for antimicrobial resistance. Because they are sick, they'll take antibiotics. The possibility of that sick person going to a hospital, getting the proper diagnostics to get the proper antimicrobial agent is low. And then, so they're probably going to take the wrong antimicrobial agent you're selecting for resistance. So the poverty complicates it, really. It really complicates it. Then you might have fake drugs in the market. That's another angle to look at. You might have them not being able to finish their dosage. That's another angle to look at. So poverty changes the narrative, just for the negative, really.
Yeah. Thank you so very much, Dr. Kome.
Sorry, Ohemu. Before you came, I think a question was asked while you were up about okay.
I think Al.
We don't have it anymore.
Yeah, I think Al might have answered that in the text in the Q&A. There was a question around R&D, production of antimicrobials, and Al's pointed to a welcome report showing that the majority of research, development, and production of antimicrobials occurs in North America, Europe, and parts of Asia. And I guess that's certainly a point to discuss that sort of the difference between where things are being produced and where AMR is a particular issue. There is a question I was going to say just in the chat. Was kind of question. It's a larger thing about how to basically address AMR in stress situations, and particularly with Sudan as a case, which I guess we can highlight the kind of AMR and conflict pages and some of the research that we have, work that we have on AMR Hub around that. But that's more about conflict as a driver of AMR rather than how to sort of conduct effective research in situations. I don't know whether there's some kind of broad ways you could address that point.
That's okay. Highlighting it, I think the hub will probably have most of the answers on that.
Yeah. Okay. Thank you, Dr. Kome. Thank you so very much for your time and effort in this. Before I let you go, I have a question for Dr. Alun. Dr. Alun, if you are still on the call, please, I would like to see your face. And this question is purely on community engagement. You spoke extensively on, engaging community engagement to tackle antimicrobial resistance. And my question for you is, what challenges did you encounter in your community engagement initiatives, and how did you influence behavioral change? Because there was a case in an African country, and some organizations wanted to provide insecticide treated mosquito nets to individuals in that region, and then they just gave them the nets, and they discovered that the community members who were actually being overwhelmed with issues of increase of malaria and mosquito bite and all of that, instead of using the mosquito net, they ended up using the mosquito net as a net for goalposts, football goalposts, and some use the net as sponge, and some actually completely use the net as scarecrow in their farms and all of that. And when the organization decided to inquire, why did you guys refuse to use what we provided? They said, the net that you provided for us it looks like a particular piece of cloth that they use to wrap dead bodies during burial or funeral services. And for that reason, they feel that sleeping under the mosquito net is more like they are also going to die in the course of their sleep or something. So for that reason, they refuse, to use the net. So that is, how do you overcome such challenges in community engagement, and how do you influence change in behavior as you go out to engage communities in such initiative? Thank you.
Yeah, thanks for that question, Ohemu. I'll answer I'll answer from what's in the literature, and then there's been a couple of literature reviews on community engagement strategies, and what they point to makes sense really from the perspective of community engagement. That if you really want to design appropriate community engagement strategies or solutions to AMR, you really have to work with communities in co-designing these strategies, so that you have, culturally appropriate, and that you don't make the mistakes of assuming that a specific technology or a specific approach in one setting will work in another setting. I think before doing it, I think the literature points to drawing from community insights towards informing community engagement strategies and approaches. I hope that answers.
Excellent. Excellent. Thank you, Alun. Get the community involved, draw insight from the community, and propose strategies that will help make the community a better place. Thank you so very much, ladies and gentlemen. If you are just joining us, this is the World Antimicrobial Resistance Awareness Week webinar put together by the AMR Knowledge Hub of the Global Health Network today, Tuesday, 19th November 2024. And so far, we've had two excellent speakers share their thoughts on assigned topics. It's been mind-blowing, honestly, listening to Dr. Alun Davies and listening to Dr. Kome Otokunefor speak on political engagement, to curb the rise and spread of antimicrobial resistance. Without further ado, it is my honor to introduce to us our third speaker for today, my colleague Louise, who put her picture on the screen as I briefly introduce her to us. Our next speaker for today is an associate professor at the University of Cape Town, where she is undertaking a Wellcome Trust Career Development Fellowship on intersectional research in antimicrobial resistance, the protease study across South Africa and India. She serves as co-principal investigator of the CAMONET South Africa Hub and is a contributing investigator to CIDRI Africa at the University of Cape Town. In the UK, our next speaker for today holds the position of honorary reader in infectious diseases, AMR, and global health at the University of Liverpool. Her contributions to AMR research have been recognized with the Academy of Medical Sciences UK India AMR Visiting Professor Award. She is dedicated to mentoring clinical pharmacists and researchers globally, supporting the implementation of antimicrobial stewardship interventions in diverse healthcare settings and economies. Ladies and gentlemen, without further ado, please join me in welcoming Professor Esmita Charani.
Hello and welcome to this talk on data-driven antibiotic stewardship. My name is Esmita Charani and I'm an associate professor at the University of Cape Town working on a Wellcome Trust Career Development Fellowship as part of the protease study that looks at intersectional research in antimicrobial resistance. So just to talk a little bit about the foundation of why data is important and why there are gaps in relation to antibiotic stewardship and antibiotic resistance. We did a review recently of as part of a grant that we were getting from the Wellcome Trust at where funding is going to in relation to antibiotic resistance. And we described inequity in existing funding structures, and majority of the funding in human populations and looking at human populations and antibiotic resistance is focused on technology development and technology evaluation. Often these are driven by high-income country needs without contextualization of the developed technologies for low and middle-income settings. There are gaps in our ability to fund effective surveillance programs, developing contextualized innovative solutions, and also implementing them, and policy evaluation. And what this does is that it creates a lack of data that is sustainable for us to be able to monitor AMR in different settings. We also looked at the existing national action plans. This is from 2023. And we included 108 country NAPs that were available at the time to look at where the data in the NAPs is coming from related to AMR. But the majority of the regions of the WHO, if you look at the WHO by region, majority of the regions actually still are not 100%, as in all countries having national action plans. Of course, with the high-level United Nations meeting on AMR this year, this is likely to change and improve over time. We looked at the data that is being used to describe the burden of antibiotic resistance in these countries that have NAPs. And a lot of the countries are using data from a single study or one site that has conducted surveillance on AMR and antibiotic use. And there is inconsistent data availability within and across countries for us to be able to benchmark the quality and threat of antibiotic resistance. Whilst all of the NAPs talk about the need to provide assured access to antibiotics, there is very little consideration for the informal routes to access in many countries. So this is from Haiti, where informal drug sellers give antibiotics or sell antibiotics to members of the public and citizens. This is from a photograph in Vietnam, in a shopping center, of all the different types of antibiotics you can buy, including intravenous antibiotics. And we then go and do all these campaigns with the public, but we need to understand the drivers for behaviors in different settings. If there is a lack of access, if there's a lack of access to universal healthcare, and people are paying out of pocket for healthcare, it will determine how they use the formal and informal healthcare market to meet their needs, their healthcare needs. We also, if we look at the context in which we're providing healthcare and infection control, so this larger photograph is from outside of a waiting area in an A&E in the UK, and this is a carer makeshift bed in a hospital in Kampala in Uganda. We have challenges regardless of where we are in the world in terms of being able to deliver safe and adequate infection prevention in our healthcare settings. The infection prevention and control is a big part of antibiotic stewardship, and I think we do ourselves a discredit if we keep talking about them in silo. The WHO has produced an IPC assessment framework, and a lot of the countries, particularly in low and middle income countries, are not doing well enough in providing or meeting all of the indicators that are considered as minimum requirements for IPC. Low and middle income countries score significantly less than high income countries in this framework or scoring system. And there are many challenges reported, including lack of staff, lack of ability to train staff, a lack of management support for IPC, overcrowding, understaffing, as I mentioned, and all of these result in impact our rates of drug-resistant infections, but also their emergence and spread. From a tertiary hospital across a series of tertiary hospitals in Bangladesh, there was inadequate IPC, and overall median score was quite low. These are challenges that many hospitals face around the world, and we have to be realistic about and agile and pragmatic about how we collect data, how we implement stewardship in different settings, and what success looks like in different settings. Having these one sort of universal goal for developing sort of an indicator for success is not going to be effective. We need to consider the population needs and the healthcare needs of different settings. We also need to define IPC interventions, and there's ambiguity around that. There's a broader range of interventions that need to be included. We need to look at the cost effectiveness of screening high-risk individuals. And also, we don't have quality studies that evaluate education and training, or specifically monitoring and evaluating infection prevention and control practices and interventions in different settings. So there's a lot of gaps in our data. So contextual variability is a limiting factor. We have to be able to look at the economic impact of implementing interventions versus the economic impact of the burden of disease in different settings. We often focus on a single microorganism, which is problematic. We need to look at have a whole systems approach to how we deal with infections. And we rely a lot on modeling. And there are, of course, flaws in the modeling that needs to be considered as well. We did an observational study at the hospital where I work in Grote Hospital, looking at the 5 moments of hand hygiene and where the pressure points are. And we just did a bedside observation. And what we found is that the majority of the opportunities for effective hand hygiene are missed by healthcare professionals. Despite there being the sort of available resources for them to adhere to hand hygiene. And this varied across healthcare professionals, but the cadre that had the most contact with the patient and therefore had the most likelihood of passing on an infection, but also of missing an opportunity for hand hygiene were nursing and medical staff. In terms of, in this context of inequality, what interventions have most robust evidence for mitigating AMR? As I mentioned, we've been working on the Lancet series to investigate this, looking at the burden of antibiotic resistance in lower middle income countries, and trying to find solutions. And the WHO is also very active in this area, looking at gender and AMR inequality. There are reports that are coming out you should watch out for. But in our Lancet series, what we identify is that in lower middle income countries, the most likely success is going to be in interventions that are focusing on WASH, on vaccines and infection prevention. These are tantamount. These are really important for turning the tide around on the threat of antimicrobial resistance. This doesn't mean that antibiotic stewardship doesn't have a role, but it does mean we need to generate evidence on antibiotic stewardship, and for that we need data. And we have a series of recommendations, including 10% reduction in AMR mortality, 20% reduction in human use, and 30% reduction in animal use. And the first one has been adopted by the UN General Assembly in their objectives, and that is something that we are happy about, and it's important. It is important to have targets, whether you agree with the targets themselves, but I think it is that evidence has demonstrated that, particularly at policy and country level, policymakers will respond to targets, and it is important to have definitive messages around mitigation of AMR. When we look at the data around antibiotic consumption and the burden of disease by the specific pathogens in different settings, there are 3 databases to which countries are invited to report data. The GLASS database, which is WHO funded, the Atlas database, which is a collaboration between Wellcome Trust and Pfizer, and ECDC, which is a European database. And we analyzed the data for the same pathogens being submitted to these different international databases for the same year, and we found discrepancies. Now, what this tells us is that, for example, this country reported 56.6% susceptibility to S. aureus for GLASS and 37.6% to ECDC for the same year. What this tells us is that there is a lack of effective surveillance systems that are sustainable and can provide accurate and reliable data to be able to inform practices. And that's a major gap. But it's not surprising when we look at the availability of resources that we have to collect data, whether it's for surveillance or for antibiotic consumption. These are just some of the current medication charts in practice in different parts of the world. So if we want consistency and benchmarking, we need to have the right tools and resources to be able to support that. And we lack this at the moment. And when we look at stewardship interventions, so this is just an example of stewardship interventions that was implemented in a hospital I used to work in the UK over the time period I was there. You know, we tried to have in blue, these are some of the key interventions we implemented. And then a lot of these were knee-jerk reactions to a crisis. We often do not have the luxury to develop and think through interventions we develop. And this is an academic institution that had the possibility or the ability to translate research into practice. And still we had challenges. And then in red is that some of the international guidelines and policies that came out around the AMR at the time, and in black are the some of the national guidelines and policies that came into place. And as we can see, it's just a very cluttered space and there's lots of things going on. But the backbone of stewardship is structural process and outcome indicators. And we were able to demonstrate and deliver to this. If I give one example of a technology that we introduced and its impact, it'll give you a window into this is a well-resourced healthcare setting and how we did this. So we had a treatment of infection policy guide, which was a pocket guide, which we gave to all of our junior doctors. And we identified at the time, now this seems very regressive now, but at the time it was very progressive. We identified that a lot of people were using their smartphones and they were using apps on their smartphones. So we worked with a company to develop an app of the policy, convert it to an app, and we found that there was a lot of positive reception to this, and that people were beginning to be more engaged with the policy. And because we had consistent data from prevalence surveys going back 10 years, and these prevalence surveys were opportunistically twice a year, pharmacists would go on the wards and collect data for, excuse me, for at least 5 patients on each ward who were on antibiotics, and consider whether the antibiotic prescribed was appropriate for the indication, whether the indication was documented, and whether a stop review was documented. And just using those 3 indicators, because we had consistent data, we could see the impact of introducing an app to the stewardship program in the hospital. And most interestingly, having dabbled in this technology and having written about the governance issues around developing technologies in healthcare, has led to a whole host of other work since, with the rapid evolvement of AI and clinical decision support systems in healthcare settings generally. So now there's a whole research team in this organization that is looking at point of care testing, using AI at clinical decision support systems to improve practices, etc. And we were also able to develop, some of my colleagues were able to develop an app for using gaming to engage with physicians around antibiotic prescribing. As I mentioned, because we had consistent data, we were able to demonstrate not only an upsurge in number of users over time in comparison to access to the pocket guide online and using the pocket guide in paper format, but also over time we noted an improvement in the 3 main indicators that we were looking at. So it was whether indication was recorded, whether the stop date was recorded for the antibiotic, and whether the prescribed antibiotic was appropriate according to the policy. So that was just an example of how data can be generated in a pragmatic way to support implementation of technologies. It's really important for us to also look at the data and the lack of it around access to antibiotics in different settings. It is not an issue of just excess use of antibiotics. In many parts of the world, it is lack of access to antibiotics that is driving AMR. And this was demonstrated in the Graham report, the Graham study by colleagues in Oxford and globally, where they demonstrated, for example, some of the highest burden is in sub-Saharan Africa. There is not an issue of access, an issue of excess use of antibiotics, is more an issue of lack of access to antibiotics. So we need to be very careful when we talk about this. But one of the issues around access to antibiotics is the issue of looking at the medication supply, antibiotic supply and availability chain, particularly focusing on the issues that can occur because of lack of economic incentives to develop new antibiotics, lack of economic incentives to develop active pharmaceutical ingredients, and the migration of a lot of the manufacturing plants to India and China to single suppliers, specifically for APIs, and the impact of this on access to antibiotics. And, you know, this drive to keep pushing for new antibiotics to be developed is problematic in itself, because when we develop a new antibiotic, no matter how good it is, by the time adequate access is given to it in low and middle income countries, it's often too late. So the R&D market really is serving high income countries before it's serving universally everybody. And GARDP is trying to change this in different ways of funding how we develop new antibiotics, which is really important in providing equitable paths to access for new agents in different settings. The supply chain is a very complicated process, and there are many different actors that are involved that we need to look at. We have been working a lot, funded by GARDP and Wellcome Trust, to generate data around the issues of antibiotic shortages. And we've just published a systematic review where we highlight the majority of the evidence on how we're managing shortages is being generated from high-income countries, which is problematic. And with the evidence that is there does illustrate opportunity costs of redirecting resources when there are shortages, particularly, for example, for stewardship teams having to redirect their resources. There is some evidence of increased drug-resistant infections and a resource drain to the hospital, including laboratory staff. And these are things that we are not considering enough, and we need to gather data from different settings, but we also need to learn from the resilience of low and middle income countries in dealing with shortages. There's also a lot of learning to be done about how stewardship is being implemented in low and middle income countries, and using the workforce differently in different settings, and the need for champions to support multidisciplinary approaches to stewardship in different settings. So the Kerala model, which we have written about, is a really fantastic model of stewardship, but it required a public-private partnership to drive this. There was a lot of integration and engagement of the stewardship leads across public-private partnerships, but also working with the colleges of pharmacy, nursing, medicine within the state, working with policymakers and political sort of stakeholders within this at the state level to be able to drive this. And what they were able to do is have this model where they tapped into both the informal and formal networks and stakeholders. And this is really important in low and middle income countries, or in many parts of the world. Well, there is a very active informal sector. We have to engage with them when we implement stewardship. And over time, they were able to develop a pharmacist-driven stewardship program that actually, when you look at the structural process and outcome indicators, doesn't look that different from the other one I showed you from the UK, but it's driven differently and is contextualized. And this slide really needs to be updated because Vrinda Nampatiri has now finished her PhD, and she looked at the role of clinical pharmacists in antibiotic stewardship programs in South Africa, India, UK, comparing the different models that are available in different settings, particularly where there is a greater public-private presence, as there is in South Africa, and what that looks like, and identifying what needs to change in different settings in different countries for there to be a greater multidisciplinary approach to stewardship programs. Antibiotic prescribing is a complex social process. So I collect a lot of qualitative data on stewardship. I've started doing this in my PhD, where we describe this set of unwritten rules and clinical autonomy around stewardship and behaviors. And, again, it comes back to data. How do we back the qualitative differences we're seeing into quantitative data? So we collected data from acute surgery and acute medicine that was considering the different ways of decision-making around antibiotic use by specialty. And everybody, when I started doing this work, told me, why are you bothering to look at surgical teams? They only ever prescribe cefotaxime and metronidazole. And of course, we demonstrated that actually they don't do that. There's a lot of qualitatively we were able to demonstrate the differences in practice across medicine and surgery, including in how blood culture and sensitivity results are used, how data are used on the ward rounds to aid diagnosis. This reliance on C-reactive protein as an infection marker in surgery, when C-reactive protein can be elevated for other reasons in surgery. The issues around ICD-10 coding, when we want to retrospectively look at indications or sort of diagnoses, infection-related diagnoses for patients. There was a lot of ambiguity around definitions of sepsis. Everybody in surgery had sepsis, whether it's chest sepsis or urosepsis or wound sepsis. And of course, sepsis is a clinical indicator that has very clear markers, clinical markers that we can use to measure. But sepsis was being used as a term for everybody to be on broad-spectrum intravenous antibiotics. And we also quantitatively collected data, and we found that in surgery, antibiotics are prescribed more frequently for longer periods of time, are more likely to be escalated post-operatively, and are less likely to be compliant with local policy than medicine. And therefore, actually, we shouldn't think of medicine as a low-hanging fruit, and we should engage a lot more with surgical teams. We replicated the study in India and South Africa as part of my postdoc, based on the findings we had in my PhD. We got an Aspires grant and with the ESRC, which specifically wanted us to look at qualitative data in relation to AMR in different settings. And I use this a lot because this was from outside of the ICU in one of the hospitals we were working in India, which demonstrates the traffic through that ICU at any given time. And as we know, the more people through a space, the more likelihood the spread of infection. So when we develop expectations for what interventions should look like in different settings, we need to bear this in mind. And then we collected qualitative data. We mapped the surgical pathway in different in South Africa and India. And we found very actually similarities in the surgical pathways in these different countries. The majority of the patients who are in hospital in surgery do end up spending most of their time on an antibiotic. Yes, cefotaxime or metronidazole is given at surgery, but it's what happens post-operatively when the patients are in the ward that is really important and of note. A lot of patients end up on broad-spectrum antibiotics. And there are 84 healthcare workers for this particular patient who were involved in her care, all of whom had a role in infection management and prescribing of antibiotics. So when we engage with stewardship, we need to cast the net really wide. When we look at culture and sensitivity from the lab, this lady had so many swabs taken from her wound, from her surgical wound, and a lot of them after she had been on antibiotics. So it's actually, not the best way to do it, but a lot of the time also the swabs were taken not in aseptic conditions or inappropriately collected, and therefore it could have been a colonization or a contamination and not a true infection. We replicated this in the pediatric pathway in India, and we found, even though there was a stewardship program, 83% of the surgical NICU patients were on broad-spectrum antibiotics for the entire duration of their stay in the NICU. And this, again, is problematic because it is not justified. Clinically and scientifically, we cannot justify it. But the physicians, when we did the qualitative study, were able to justify it to themselves. Again, it was about fear of sepsis. They considered the surgery to these patients to be complicated and vulnerable. And one thing that stood out for me was one of the physicians telling us, Indian children are malnourished unless proven otherwise. So your global guidelines don't work for our children. Of course, this is actually not true in this hospital. This is a public-private hospital where a lot of the patients are actually affluent and are not considered to be malnourished. So lastly, I want to show you another study that was done by my colleague, Dr. Dina Vandenberg and Professor Angela Dromowski. And this is a very small funding that they received to do this incredibly extensive work across 14 hospitals in South Africa, public-private hospitals, and they implemented a stewardship in the NICU. And they did this by targeting the stewardship teams in each of the neonatal units in the participating hospitals. Sorry, it was 12 hospitals, not 17 or 14 hospitals. I said 12 hospitals, 6 private, 6 public. And they were able to show over time a reduction in mean length of antibiotic therapy. But a lot of the work was actually handshake stewardship, if you like. It was about committing to engagement with the multidisciplinary team in each of the hospitals to look at how stewardship could be implemented using the nursing staff and engaging with the pharmacy staff as well as the clinical staff. So it was a very deliberative and prolonged process of really engaging with the teams and negotiating changes with them, behavior change with them, rather than changing the guideline or restricting antibiotic use. And so I think there's a lot to be said for the longer term effort that is needed to be put in place in different settings when it comes to implementing stewardship effectively using data. I'm going to stop talking here. And again, I'm going to thank the organizers for inviting me. I have a large team of colleagues that I work with in South Africa and India. And our work is funded by the Wellcome Trust, by the WHO TDR, and we work in collaboration with AWAAW. That is a Wellcome Trust NPO that engages in public and community engagement. I don't have time to talk about their work today, but they also do amazing work. Thank you very much.
Thank you so much for your presentation. We are glad that you could make this presentation available to us. Participants, we sincerely apologize. Professor Esmita is not live with us today because she's currently out in the field for a research study, and she foresaw that there's going to be network issue in the field, that she won't be able to connect and make her presentation live. So she decided to pre-record her session and she sent it across, and we've been able to deliver it to you. We apologize for the low volume encounter that we had earlier, but I believe my colleague Louis and the support team were able to fix it, and you could hear Professor Esmita present clearly. Thank you so very much, ladies and gentlemen. If you have any question that you'd like us to serve to Professor Esmita, you can drop it in the Q&A box. We'll do our best to email her those questions and copy you in it so that when she responds, you'll be able to get the feedback that you deserve. If you have any burning question for our two previous speakers who are live on the call, Dr. Alun Davies and Dr. Kome, if you have any question for them, you can do well to drop them in the Q&A box, and they will give their response to those questions as soon as possible. I'll just look at the chat box and be able to see if we have any question from anybody. All right, it is all about thank you, and appreciation coming in from participants that the session has been very, very impactful. Ladies and gentlemen, we are gradually coming to the end of today's webinar. Before we draw the curtain, I'm going to invite my colleague, Adam Dale, Knowledge Exchange Coordinator of the Global Health Network, to give the closing remark, after which we'll call it a day. Thank you, Adam. Welcome.
Many thanks. I'm just going to say really a quick thank you to everyone today. So Ohemu, obviously, for organising this great event, and for yesterday as well. It's very important as part of AMR Awareness Week to bring people together in this area. Thank you to Louis to help organise the webinar, and to our speakers, Alun, Kome and Esmita as well. Just to really see the value of the importance of collaboration and the broad concept of knowledge exchange around AMR with community members, with policymakers, and amongst researchers as well. And just say, please do, the concept of get out there and there being an action from this, to advocate the actions of go out and share knowledge that you've had with each other. Please, you can do this through the AMR Hub by connecting through the Connect and Collaborate and link up with each other and share knowledge. Any questions that you have or further ideas or anything, please do get in touch with us. We really, really want to hear from people and link people up. And just say we will continue to develop what we do to support AMR research across the global health network. So any ideas to help us with that, please do get in touch. There's a QR code on screen there, which is just if you haven't signed up to the AMR Hub already, that's one way to do it. And we hope to have many similar events like this in the future. And we'll certainly see you way before the next AMR Awareness Week with plenty of other events and resources. So again, thank you everybody for joining, and thanks everyone for contributing. Have a great day.
Thank you.
Evening.
Thank you so very much, Adam. Ladies and gentlemen, this is where we'll draw the curtain today. A bunch of thanks to our speakers, Dr. Alun Davies, Dr. Kome, Otokunefor, and Professor Esmita Charani. Everybody and our participants, thank you so much for honoring our invitation. We look forward to sharing the recorded session with you as soon as the support team is done editing it. And also you can check on the AMR Knowledge Hub often for latest resources, toolkits and databases, and information about scholarship, fellowship, funding opportunities. All of those stuffs are announced on that page, and we feel they will be of added value to you. So until we come your way again, my name is Ohemu Godwin Pius, and it has been an incredible honor to chair today's meeting. Let's continue to go blue for AMR, and let's connect again in 2025 for another interesting section. Do have a wonderful morning. Bye for now.